today to speak about this approach, the Subxyphoid approach, and we have to see if it's again changing in our surgical techniques. Just a brief introduction, as Professor Bess say, the surgery is still a keystone of the Thymic Epithelial Tumor, and we based our decision of our benchmark, which is the rhythmic French national network. We have to remind two fundamentals of the surgical approach. The first is the need of quality of surgery, and we are based on our previous published by the European Society of Thoracic Surgeon, which is one of the largest society from the thoracic surgery. 10 years ago, we published a retrospective survey issue from 35 centers and more than 2,000 patients. The predictive factor of recurrence was advanced mesothelioma stage, the histology of thymic carcinoma, and the incomplete resection. And we have to focus on this part because this is the only changeable factors that we can have on the poorest postoperative course and recurrence course in case of this incomplete resection. The second part of surgical approach is the extent of thymectomy, and on the same group, Thymic group in this society, we published 4 years ago a retrospective study, more than 2,000 patients also, and there was a large range of recurrence in case of thymectomy alone in comparison to thymectomy and enlarged thymectomy. For this Subxyphoid thymectomy approach, we divided this presentation in two parts. The first part, it was we are sure about this technique. Yeah. We are sure that it's a minimally invasive approach and can be both made by video assisted or robotic assisted surgery. The second part of this presentation, we will also focus on the attempt of this technique. We are sure that Subxyphoid thymectomy is a minimally invasive approach, and we don't have to discuss a long time on the benefit of this strategy. We have so many literature on that, especially we can cite this retrospective study published in 2019 with painless and has recovery based on the same oncologic result. As a minimally invasive technique, work group in France published the recommendation based on the rhythmic and hypnic, which is surgery for both diagnostic and therapeutic strategy, and which is recommended for lesion less than 5 centimeters on first and early stages. Historically, we based our strategy on a unilateral and lateral approach, right on left, based on the tumor localization and surgical expertise, but we recently moved on the bilateral approach on supine position, which is most physiological approach. We have a strategy and surgical approach can be both VATS and WATS technique, and we will discuss the retrospective meta-analysis for VATS published last year, but we have an obligation to cite the first report of robotic thymectomy by the Subxyphoid approach published a decade ago by Dr. Tsuda, who was the precursor of this technique. For the VATS strategy, we can have a meta-analysis, but it's based only on 7 high-quality reports from the worldwide literature, and all the reports are in favor to Subxyphoid approach in comparison to previous unilateral and historical lateral thoracic transthoracic approach with benefit on postoperative drainage, but especially on pain score at day 1, 3, and 7. For the robotic surgery, I produced this excellent propensity score match comparison study by an experimented South-Korean team. We published over more than 3,050 patients and show a shorter hospital stay with lower pain in Subxyphoid approach. We can note in this study the excellent completion rate was over 98% in the 2 category of surgical approach, we reflect a high score of surgical skills. For the second part, we have to discuss the standardization of this technique. On the first slide, we can see the Dr. Tsuda approach, which is on all subxyphoid and subcostal approach, avoiding all for placement in the intercostal spaces, in comparison to Dr. Park and the South Korean team. We had systematically 2 intercostal port, and we have some mix of this kind of technique. So for the standardization of this technique, the answer will be no. They don't have today any standardization. We can't have a numerous number of ports, and especially in their localization with intercostal or extrathoracic and subcostal ports. The 2 parts of this standardization is to answer the question, does we just want to have a better view and the camera in the median part will be sufficient, or just we have to want to avoid intercostal pain, and philosophically we have to put all the port in extrathoracic part and the subcostal and subxyphoidal approach. For that is more standardized, but we find less utilization in the literature. So for the standardization, I think we have to define some precise terms. Does we have just an extrathoracic and exclusive extrathoracic approach without intercostal focal port spaces, or does we have a combined approach with a mix of subxyphoid and intercostal port? And we can discuss what is the matter for us. Does we have benefits of this technique? From a subjective point of view, yes, we have an improved vision, and we seem to have an easier way to extract the large tumor, especially because there is a soft area extraction zone. It seems to have painless and shorter stay in our hospital. But from an objective point of view, I think it's still uncertain because we have a lack of strong data, especially in robotic technique, because the publication focus on enlarged surgery to the vessel or the pericardium, and so they can mix technique between lateral and subxyphoid approach. We have to question about the control group that is still used. Does we have to maintain some historical unilateral approach and a few decades was published and used 3 decades ago, or do we have to move for this control group in a bilateral supine approach? And does we have to compare that to that surgery, or does we have to compare each approach in each techniques? That's why I think this retrospective multicentric study published last month is still important, because based on more than 1,000 patients, we don't have any difference in the strategical VATS or WATS surgery approach. But in the subgroup analysis, we can show that WATS seems to be superior to VATS in unilateral transthoracic approach, despite VATS seems to be superior to WATS in subxyphoid approach, which can be different than the previous robotic and large unilateral retrospective study published. So I think for my take-home message and for my conclusion, subxyphoid thymectomy seems to be a promising minimally invasive technique, but not still a game-changing strategy. We have to reflect about the extrathoracic surgery for painless, and maybe as often as we can, don't put any intercostal port. There is still no evidence of superiority in comparison to other minimally invasive techniques, and we have a need of standardization of this strategy and large multicentric prospective trial. We don't have to forget the learning curve, which can be between 20 and 50 patients, especially in this rare tumor strategy. And the first and most important message is to don't forget the first surgical objective, to make a radical and complete resection to avoid rapid recurrences. So this is not just advertising, we have to put some quality resection. and the conversion in sternotomy or in other minimally invasive technique, if you don't have a good access to the subxyphoid port, must be synced, and that is not a failure of this strategy. Thank you for your attention.